The first subheading within that group is preoperative assessment, and we begin in turn that under the subheading of cardiac risk. Now, if this exam that we are preparing for were to be the boards in anesthesia, there would be an enormous amount of detail in the preoperative assessment of operative risk. But for the purpose of a general licensure exam like the USMLE, we're going to hit upon the highlights only. And one of the things that I think might be most suitable as examination material are those conditions that pretty much everyone should be able to recognize as precluding doing surgery or posing such a high risk that other preparation steps are required before a patient could undergo an operation. So let's begin with this cardiac risk. Vignette number 1 is a 72-year-old man with a history of multiple myocardial infarctions, is scheduled to have an elective sigmoid resection for diverticular disease. A preoperative radionuclide ventriculography shows an ejection fraction of less than 0.35. This is a no-go situation. One cannot subject a patient to an anesthetic in an operation whose ejection fraction is less than 0.35. This individual will be at extremely high risk of having an intraoperative myocardial infarction, and in turn that one would have a very high risk of leading to death. The normal ejection fraction, as you know, it's like 55% or maybe even a little higher than that. So this is what this would relate to as a normal value. And so were you to have this question, what should we do with this patient? The only correct answer would be one that seeks and offers a non-operative management for this problem. Vignette number 2, a 72-year-old chronically bedridden man is being considered for emergency cholecystectomy for acute cholecystitis that is not responding to medical management. He had a transmural myocardial infarction 4 months ago and currently has atrial fibrillation, 8 to 10 premature ventricular beats per minute, and jugular venous distension. Now, this gentleman also has pretty prohibitive operative risk at this time. And in fact, this vignette was written the way it is to bring up each and every one of the elements that have been recognized as increasing operative risk for non-cardiac surgery. And a gentleman by the name of Goldman has taken the trouble to compile all these predictors of risk, and this individual is a compendium of all of the Goldman's findings. The age of the patient, the fact that he's chronically bedridden, the fact that the operation is an emergency, the fact that the operation gets into a major body cavity, and then all of the other things that are described. He had an infarction, he has atrial fibrillation, he has premature ventricular contractions, he has jugular venous distension. If you were an anesthesia resident preparing for your board exams, you would be expected to assign numbers to each of these and to be able to quantify operative risk. I think for the USMLE you don't need that, but you need to know that this is an individual who has every conceivable finding that indicates he has a very high operative risk. Actually, one of those, though, is the worst of the lot. So let me identify that one in the next vignette, vignette number 3. A 72-year-old man is scheduled to have an elective sigmoid resection for diverticular disease. In the preoperative evaluation, it is noted that he has venous jugular distension. In that setting, this means the man is in congestive heart failure, and we cannot do elective surgery in the presence of congestive heart failure. So this individual must be managed medically to get him out of congestive failure if at all possible. So he may need calcium channel blockers or beta blockers or digitalis or diuretics. I'm not going to go into those details that belong more properly on a medicine review. But the point is, jugular venous distension in this setting doesn't mean pericardial tamponade or tension pneumothorax like we did in the trauma vignettes. It means congestive heart failure. We cannot operate at the time. And in fact, this vignette leads a series of a few vignettes where there is something we can do to improve the risk. In this case, the something was medical management to get him out of congestive failure. Let's look at the next one. A 72-year-old man is scheduled to have an elective sigmoid resection for diverticular disease. Obviously, this could be any other kind of elective operation, all right? In the preoperative evaluation, it is ascertained that he had a transmural myocardial infarction 2 months ago. A recent myocardial infarction, and recent means under 6 months, tremendously increases operative mortality for non-cardiac surgery. If surgery were to be done within 3 months of an MI, we're talking about nearly a 40% mortality. If we do the operation after 6 months, though, brings it down to about 6%. So what to do here is obvious. What we have to do here is wait. So if at all possible, this elective operation shouldn't be done now, that the infarction is only 2 months old. It should be done 4 months from now when the infarction is already 6 months old. Again, number 5 is another example where something could be done. A 72-year-old man who needs to have elective repair of a large abdominal aortic aneurysm has a history of severe progressive angina. If we operate him for his aneurysm, and he needs that, a large abdominal aortic aneurysm should have surgical repair. But if we do it while he has the severe progressive angina, he has very high risk. The answer here is he should first be evaluated for potential coronary revascularization. We have no guarantee that he will be a suitable candidate, but if he is, then we can operate him for the coronaries first. And after he's had his myocardial revascularization, we could then resect his aneurysm with much better risk. All right, we move now to pulmonary risk. For all practical purposes, and again, within the framework of a very abbreviated review, the pulmonary risk that makes patients high risk for surgery are all related to smoking, and they primarily affect the ability of a patient, or I should say the inability to ventilate properly, rather than the inability to oxygenate properly. Vignette number 6, a 61-year-old man with a 6-pack-year history of smoking and physical evidence of chronic obstructive pulmonary disease, COPD, needs elective surgical repair of an abdominal aortic aneurysm. He currently smokes 1 pack per day. Severe COPD, the long history of smoking, we know he's going to be at high risk, and we know it's going to be related to ventilation. If you're asking what would be your best laboratory test to quantify his degree of risk, either be blood gases where you're looking for the PCO2, which would be higher than normal, or pulmonary function studies where you're looking at the FEV1, which is a good measurement of the ability to ventilate. But there is an important angle to this question here. It is possible to improve the situation. Cessation of smoking for 8 weeks and intensive respiratory therapy, physical therapy, expectorants, incentive spirometry, humidified air. If we can do that before the operation, we can operate with a much better risk. Don't quickly answer, incidentally, they might say, stop smoking for a week and operate. Because when you stop smoking, you first get bronchorrhea. an enormous amount of secretions, and if we operate him a week after he stopped smoking, he's probably going to be worse off than he was if we had operated him when he was smoking. So we should be able to have a cessation of smoking for 8 weeks. We move down now to hepatic risk. The bottom line on the hepatic risk essentially is that we need a functioning liver to be able to take an anesthetic and an operation. Anything that shows that the liver is in a marginal functional situation precludes doing safe surgery. Vignette number 7. A cirrhotic is bleeding from a duodenal ulcer. Surgical intervention is being considered. His bilirubin is 3.5, his prothrombin time is 22 seconds, his serum albumin is 2.5, and he has encephalopathy. Please don't operate. This man will die. We have a collection here of things, any one of which alone would already have indicated bad prognosis when they are all happening at the same time. This is prohibited. Let me point out that we're looking at things that indicate liver function. We can and routinely operate on people with a bilirubin or 10 or 15 or 20 if it is due to obstruction, or even if it is due to hemolysis. But if it is due to hepatocellular dysfunction, a bilirubin of 3.5 already indicates extremely high mortality. Well, you add to that the prothrombin time, the serum albumin, the encephalopathy. This is not a surgical candidate. In fact, if we were to quantify his mortality, it's pretty much 100%. Now, any one of these alone, given to you in a vignette, if it's a little more deranged than I had on vignette number 7, would also pretty much prohibit surgery. Let me read them quickly. Vignette number 8. A cirrhotic with a blood ammonia concentration above 150 nanograms per deciliter needs an operation. A cirrhotic with an albumin level below 2 needs an operation. A cirrhotic with a bilirubin above 4 needs an operation. Any one of those, that operation cannot be done, because the degree of hepatic dysfunction that each one of these illustrates, it's extremely grave prognostic finding. Death, incidentally, occurs with high output cardiovascular failure with low peripheral resistance. That's the way people die in liver failure. And this, I'm mentioning because this may be what the vignette gives you. The exam questions might say, if we operate a patient with these parameters, what is the expected outcome? And rather than saying he's going to die, it might say high output cardiovascular failure with low peripheral resistance. That will be the way the patient will die. Now we move to another topic that has become of great interest in recent time, nutritional risk. Let me read the vignette and then let me explain the background. An elderly gentleman needs palliative surgery for a cancer of the esophagus. He has lost 20% of his body weight over the past 2 months, and his serum albumin is 2.7. Further testing reveals allergy to injected skin test antigens and a serum transferrin level of less than 200 milligrams per deciliter. This is a man who is severely malnourished. We can judge malnutrition simply by knowing that a patient has been unable to eat and has lost weight. But if we want to be a little more precise, the weight loss exceeds 20% of body weight in a short period of time. This is a very significant level of nutritional deficiency. If the serum albumin is below 3, in this example I gave you 2.7, this is significant nutritional deficiency. If there is allergy to skin test antigens like tuberculin, another sign of extreme nutritional deficiency. And finally, the serum transferrin level. We don't do that very often in regular clinical work, but this is another one of the serum proteins that reflects nutritional status. If it is less than 200, it means severe nutrition. Now, we have known intuitively for years and years that a malnourished individual has a higher risk for surgery. But recently, by recently I mean within the last decade or so, there was a large multi-institutional study done in the U.S. by the VA system, where actually this was quantified. And indeed, patients that are severely malnourished have a much higher operative risk. And I'm not talking about 10% or 20 or 50% higher mortality rate. It's many-fold higher than it would otherwise be. So yes, this is a problem. But the surprising thing that came out of that story is that a brief period of time of intensive nutritional support can go a long way to lower that operative mortality. As little as 4 or 5 days of preoperative nutritional therapy, preferably 7 to 10 days, preferably delivered in the gut rather than the vein. So if you're given this vignette exactly as I read it, the man needs the palliative surgery for the cancer of the esophagus. Your correct answer is the one where for 7 to 10 days we place a little feeding tube, hopefully endoscopically past the cancer, feed him intensively into his GI tract, and then do the operation. He'll do much better than we operate on him tomorrow. We move now to metabolic complications. The only one that I'm going to touch upon is an extremely common one, vignette number 12. An elderly diabetic male presents with a clinical picture of acute cholecystitis that has been present for 3 days. He's profoundly dehydrated, in coma, with a blood sugar of 950, severe acidosis, and ketone bodies all over the place. Bottom line, we cannot operate this individual now. One cannot do surgery in the presence of diabetic ketoacidosis. This patient will need to be rehydrated first, will need to be getting out of coma, the acidosis has to be corrected, if not all the way to 7.4, at least much closer to a normal level, and the blood sugar level again has to be lower. So the correct answer here is the one where we embark in the standard medical management of diabetic ketoacidosis before we consider the surgical management of his gallbladder. I might point out incidentally that as long as a inflamed gallbladder is in place, it may be impossible to bring all of the parameters of the diabetes to complete normal levels, but at least a beginning in the direction of normalization is mandatory. Now we move to post-operative complications. The first one in our agenda is fever, post-operative fever. Now this post-operative fever might be the more standard type of fever, 101, 102, developing during the post-operative period, or it could be rather extreme, very high fever, developing much closer to the operative event. When we are dealing with a normal kind of fever, the 101, 102, that we shall see illustrated in a number of the vignettes, we have in fact a set of situations that are most likely to be responsible for it. When we have, on the other hand, extremely high temperature, then there are a couple of very specific things. Let's read the vignette and we shall identify them. Vignette number 13. Shortly after the onset of a general anesthetic, with inhaled halothane and muscle relaxation with subsumilcholine, the patient develops rapid rise in body temperature exceeding 104. Metabolic acidosis and hypercalcemia are also noted. A family member died under general anesthesia several years before, but no details are available. This is indeed a feared anesthetic complication known as malignant hyperthermia. It's due to the absence, congenital absence of one of the enzymes needed to break down the succinylcholine, and this is why it happens in families, and this is probably the reason why the relative died. And in fact, in modern anesthetic practice, that would have raised the red flag when the anesthesiologist found out that the patient's relative had died under anesthesia. But as we look at this from the viewpoint of taking the exam, the minute you began reading this question, and you were told that whatever it is that's about to be described occurred shortly after the onset of a general anesthetic, and you are told exactly the anesthetic agents. This was inhaled halothane and muscle relaxation with succinylcholine. You should already know this is going to be an anesthetic complication. If not, why are you being given so much detail? If this, if the events that are going to transpire later on in this vignette relate to the surgeon making a hole in the vena cava, then it's sufficient to know the patient is under general anesthesia. So the minute you read it was halothane, it was succinylcholine, this is going to be an anesthetic complication. And indeed, those are the two agents most frequently seen in the patients that develop the malignant hyperthermia. And then you have the body temperature exceeding 104 and the other manifestations. We treat these, interestingly enough, with another muscle relaxant, IV dantrolene, because that one works in a different way than the succinylcholine, and that stops the muscle activity, which is in fact leading to the hyperthermia. What's happening here, and I realize this is an oversimplification, probably an anesthesiologist would laugh at the simplicity of my explanation, but what's happening here is the muscles are staying at that level of increased activity that you have before the muscle relaxation is achieved, and they are generating the heat, and they're left alone, they're going to kill the patient. So we interrupt the process with the dantrolene, plus the obvious support measures if you have high temperature. 100% oxygen, correction of acidosis, cooling blankets, and one other detail. If the muscles have been generating the heat, the muscles have also been damaged by the process, they may have released myoglobin into the system, so we need to watch for myoglobinemia and myoglobinuria and treat accordingly if necessary. Now, vignette number 14 gives us another example of very high fever. 45 minutes after completion of a cystoscopy, the patient develops chills and a fever spike to 104. This close to the triggering event within 45 minutes. And the triggering event being an intrusive, invasive procedure. And the urinary tract is a classical site where that could happen. This is bacteremia. These are bugs in the blood. So the answer for the management here is blood cultures times 3, like they always are, and then empiric antibiotics, and then switch into whatever the blood culture suggests as the best therapy. And now we move to the more, quote, common levels of postoperative fever. Year number 15. In the first postoperative day after an abdominal procedure, a patient develops a fever of 102. If this is happening for the first time on day 1, postoperative day 1, this is most likely due to atelectasis. So even though we would look at every other potential reason for fever, we're going to zero in on the examinations that are going to demonstrate the atelectasis. So what would be the most likely exam to confirm your suspected diagnosis? It would be chest X-ray, even though we also would look at the wound and the IV sites and inquire about urinary tract symptoms and so on. The therapy begins by improving ventilation, deep breathing, coughing, postural drainage, incentive spirometry, and the ultimate therapy for very recalcitrant atelectasis would be bronchoscopy. It's rarely needed, but if if it's needed, that's the way. We get into the tracheobronchial tree and take out the plug that is causing the atelectasis. Now let's take this one situation a little further. Vignette number 16. In the first post-operative day after an abdominal procedure, a patient develops a fever of 102. The patient is not compliant with therapy for atelectasis. And by the third post-operative day, he still has daily fever in the same range. This is no longer atelectasis only. Now pneumonia has developed. And this is a sequence that is often seen in the clinical setting, because the treatment of atelectasis essentially depends on the cooperation of the patient. We can advise what needs to be done, but what needs to be done has to be done by the patient. The patient is the one who breathes and coughs and moves. And so it does happen that if a patient is not compliant, it goes on to pneumonia. Well, now will not be sufficient to continue the deep breathing and the coughing and the exercises. We now have a pneumonic process. So now we need chest x-rays, sputum cultures, and the appropriate antibiotic therapy. Vignette number 17, we have a patient who had major abdominal surgery, is afebrile during the first 2 post-operative days, but on day 3, he has a fever spike to 103. When the first manifestation of fever is on the 3rd day, the most likely cause is urinary tract infection. And so again, even though you would listen to the lungs and perhaps check a chest x-ray and so on, if you're asked which test is most likely to confirm your diagnostic hypothesis here, it would be the urinalysis and the urinary culture. And then you would need to place the patient on the appropriate antibiotics. If we move to a little later in the post-operative period, vignette 18, a patient who had major abdominal surgery is afebrile during the first 4 post-operative days, but on day 5, he has a fever spike to 103. Now this far out, deep venous thrombosis becomes one of the most likely sources. It could be an early wound infection, it could be a late manifestation of urinary tract infection, but again, now the most likely explanation for the fever is deep venous thrombosis. Physical exam is pretty much worthless to elicit the findings here. Every textbook has said, that we look for the Holman sign and we squeeze the muscles on the leg, and that's worthless. The accuracy of that is 50% at best. Nowadays, we have, though, a better way. We could do Doppler studies, and the Doppler studies may show us if those deep veins have flow or do not have flow. And then vignette number 19, a patient who had major abdominal surgery is afebrile during the first 6 post-operative days, but on day 7, he has a fever spike to 103. With this late onset, now the most likely site is the wound itself, wound infection. And so physical exam of the wound is most likely now to demonstrate that there is a wound infection. Now that wound infection could be at the level of just redness, but without the collection of pus. Or it may already have pus. Physical exam may be able to demonstrate, is it only erythema, is it only an infection of the soft tissue, or is there already pus, there's fluctuation, because the therapy would be different. If there's only erythema, we can take care of that with antibiotics. If there is, on the other hand, the collection of pus, it needs to be drained. Were you to be asked to differentiate between the two, and I'm going to repeat this in a later vignette, a sonogram is a good way to tell. Okay. These 4 vignettes that we just looked at, medical students remember this sequence with a little mnemonic, the 4 W's. Wind, water, walking, and wound. Wind being the reminder that the earliest post-op fever is due to inability to ventilate, to atelectasis. Water being the reminder that urinary tract infection is the one that comes next in the sequence. The walking refers to the patient not walking, not moving the legs, and therefore getting the deep thrombophlebitis. That is then the source of fever. And finally, the last W is the wound, which is the wound itself. After this mnemonic of the 4 W's wasn't used for many years, W's began to be added to it. Because it turns out that if you have a deep infection, like a subphrenic abscess or a pelvic abscess, the fever is likely to begin even later than the ones we've talked about. Let me read vignette number 20. A patient who had major abdominal surgery has a normal post-operative course with no significant episodes of fever until the 10th day, when he begins to spike temperatures up to 102 and 103 every day. When it begins that late, 10th day, then probably it's a subphrenic abscess or a subhepatic abscess, perhaps a pelvic abscess. These abscesses are very easily diagnosed today. You do a CT scan or you do a sonogram, you see them. But before CT scans and sonograms were available, these were very difficult to diagnose because plain X-rays did not show them. The pus had the same density of the other tissue. And so another W was concocted for the mnemonic here, and it was wonder where. The patient had fever, you suspected the patient had an abscess, but you were wondering where that abscess was because you couldn't see it or feel it with your hands. Well, we no longer have to wonder. We do the CT scan, we do the sonogram, but the mnemonic is still there. So fever on the 10th day, that old wonder where deep abscess. In fact, there's another W. Sometimes the medications we give the patient are responsible for the fever. So when everything else has been ruled out and the patient still has fever, we think of wonder drugs as a potential cause. Let's move now to another topic. And this is chest pain developing in the post-operative period. Let me read vignette number 21. On the second post-operative day after an abdominoperineal resection for rectal cancer, a 72-year-old complains of severe retrosternal pain radiating to the left arm. He also becomes short of breath and tachycardic. When we have exam questions where the central theme is very severe chest pain in a post-operative patient, there are going to be two things. It's either a myocardial infarction or a pulmonary embolus. And our first clue is when did it happen in the post-operative period. The perioperative MI, the myocardial infarction that is a consequence of surgery, invariably happens in the first day or two. I would say certainly within the first few days. The pulmonary embolus, on the other hand, typically takes longer to develop. You have to have the deep venous thrombosis, the clot has to form in the vein, the tail of the clot has to break and go to the lungs. So the PE, the pulmonary embolus, we typically see on the 5th, 6th, 7th post-operative day. So when we have a vignette with chest pain, severe chest pain in a post-operative patient, the first thing we look at, when did it happen? Actually, this one is otherwise pretty classical, isn't it? The pain is retrosternal, it radiates to the left arm, he gets short of breath, tachycardic, this is an MI. So obviously, the first thing to do here is both EKG and cardiac enzymes. And then whatever we typically do for an MI, but with one very significant difference. When a patient comes to an emergency room having developed a myocardial infarction at home, unrelated to an operation, our best therapeutic weapon is the clot busters. The enzymes that dissolve the clot that is now in the coronary vessels, but unfortunately we cannot lyse clots in a fresh post-operative patient. We need those clots in all the blood vessels that were transected during the operative act. So we cannot use a clot buster. And our management, therefore, is limited to the other complications that we could have, the arrhythmias and so on. And not surprisingly, perioperative MIs have a much higher mortality. from the MIs that happen under other circumstances. But having reviewed this vignette, let me point out that actually what vignette 21 depicted is really not the most common way for a perioperative MI to show up. Most of them don't show up with a classical chest pain. They show up either with the complications of the MI or the electrocardiographic finding. Let's read vignette number 22. During the performance of an abdominoperineal resection for rectal cancer, unexpected severe bleeding is encountered, and the patient is hypotensive on and off for almost 1 hour. The anesthesiologist notes ST depression and T-wave flattening in the EKG monitor. This vignette, in fact, is classic. The people who get the perioperative MIs are older individuals that have big operations, and by far the most likely triggering event is hypotension. Here we have a patient with hypotensive on and off for an hour. He's a candidate for an MI. And it is manifested in the EKG monitor. The next thing you do here, of course, are the cardiac enzymes that confirm the diagnosis. CPK, MV isoenzyme would be a good choice. And then, as I pointed out before, the treatment for the complications of the MI, but unfortunately without the help of the clot busters. A variant of this vignette, incidentally, could take place in the intensive care unit. The patient could already be out of the operating room, but in the intensive care unit, where he is also hooked up to a monitor. And he may not be saying, I have chest pain, but the monitor shows the EKG changes. Vignette number 23 gives us the other common cause of severe chest pain in a post-operative patient. On the 7th post-operative day, and there is the first clue, right? On the 7th post-operative day after pinning of a broken hip, a 76-year-old man suddenly develops severe pleuritic chest pain and shortness of breath. When examined, he is found to be anxious, diaphoretic, tachycardic, and he has prominent distended veins in his neck and forehead. Here we have another clinical situation that is likely to produce distended veins. In this case, it is from the massive pulmonary embolus. All right, so we have every indication here. The timing, remember, was our first clue. This is 7 days post-op, very likely to be a pulmonary embolus. And then the nature of the pain goes along with it. The big distended veins go along with it. If I ask you what's the first thing you do next, you do blood gases. Because arterial blood gases have a very characteristic finding that orients you in the direction of saying, yes, this was a pulmonary embolus. You're going to find hypoxemia and hypocapnia. This is different from the standard situation of respiratory failure, where you have hypoxemia and hypercarbia. In plain respiratory failure, you cannot put oxygen into the blood and you cannot get the CO2 out of the blood. But in the pulmonary embolus, you cannot put the oxygen in the blood, but in fact the patient is, if anything, hyperventilating. And all of the areas that happen to be perfused are also ventilated, because the disparity now between perfusion and ventilation is an area is not perfused, but is ventilated. And so hypocapnia is classical. In fact, if the vignette were to say the patient is hypoxemic with hypercarbia, I would seriously doubt that this is a pulmonary embolus. And then the next test would have to be the definitive proof that there is a pulmonary embolus. Let me take a little time here, because what the definite proof is has changed a little bit over the years. Every textbook says the gold standard is a pulmonary angiogram. Pulmonary angiograms are almost never done in this clinical setting. It's a cumbersome, difficult thing to do in the setting that we're describing. So faced with the practical difficulty of doing a pulmonary angiogram, we have relied for years and years on a ventilation perfusion scan, a test done with radioactively labeled material that gives us a picture of what areas of the lung are ventilating, which areas are perfusing, and shows the disparity of the areas that are being ventilated but not perfused. However, I have to say, clinicians have never been happy with the ventilation perfusion scan, even though it has been commonly used as the thing by practical necessity we have to rely on. It works only if the lungs are otherwise normal. If the patient happens to have atelectasis or a pneumonic process, the test then doesn't work, because you no longer are going to see completely normal ventilation with the only thing missing being perfusion, because the atelectasis or the pneumonia don't have the ventilation. There is a new test now that more and more institutions are relying on, and it's the spiral CT scan. You might recall when we had the trauma vignettes that we talked about the traumatic transection of aorta. And when we talked about the traumatic transection of aorta, we said the very first test we do after we look at the chest X-ray is a spiral CT scan. The spiral CT scan is a very good quality, high definition CAT scanning of the chest that gives us a lot more detail than the older CAT scans did. And the same way that the spiral CT scan has now made arteriogram often unnecessary to diagnose a traumatic transection of aorta, it's giving in many cases the diagnosis of a massive pulmonary emboli in a more reliable way than the ventilation perfusion scan did. Now, this is a pretty recent application of this test. It may not be on the exam questions yet, but if it is, that's the answer to pick. Well, we're not through yet with this. We have diagnosed it, now we need to manage it. So if we have confirmed the patient as pulmonary emboli, the first thing we do then is we put the patient on anticoagulants. Heparin is typically what we begin with. The anticoagulants are not going to do anything for the clot that's already in the lung. But interestingly enough, we don't need to do anything for that clot, because of all the organs in the body, the one that has the most active, naturally occurring system for lysing clots happens to be the lung. So we don't need clot busters. The lung will take care of a clot that's there. What we need, though, is to prevent new clots from giving us more pulmonary emboli. So the tail of the clot that broke off and gave this one is going to be replaced by another tail of the clot if the patient is not anticoagulated. If the patient is placed on heparin, then there'll be no further production of a fresh clot that can break and give a second pulmonary emboli. If for some reason the patient could not be put on heparin, then a vena cava filter would have to be placed. More commonly, that would be a Greenfield filter. And that would also be the answer. The vignette says the patient had a pulmonary embolus, he was properly anticoagulated with heparin, and in the presence of proper anticoagulation, he gets a second pulmonary emboli. In that case, then again, the vena cava filter would be the correct answer. As we continue to review postoperative complications, we have a couple of more that have to do with pulmonary complications as well. The first one is something that is really something we fear, something we prefer to prevent rather than treat. Let's read vignette number 24. An awake intubation is being attempted in a drunk and combative man who has sustained gunshot wounds to the abdomen. In the ongoing struggle, the patient vomits and aspirates a large amount of gastric contents with particular matter. Well, this is aspiration. This is a serious problem. This can kill the patient either right away or produce chemical injury to the tracheobronchial tree, subsequent pulmonary failure, secondary pneumonia. And this is why we would rather prevent this injury. That's why patients that have elective surgery are kept NPO after midnight on the night preceding the operation, so they approach surgery with an empty stomach. That is also why, before the anesthetic induction is done, patients are given antacid to drink. But it happens in the emergency situation, like it does here, that one unfortunately has to operate on a full stomach, and this can occur. What do we do once it has happened? Well, lavage and removal of particulate matter is the first step. And this is done with the help of bronchoscopy. So if you were given this vignette on the exam and asked what should be done next, what needs to be done next is bronchoscopy for lavage and removal of particulate matter. This is then followed with bronchodilators, respiratory support. And let me mention one item for which there was some enthusiasm in the recent past, which is no longer considered to be necessary, and that's steroids. And the role of steroids came because of studies where, in the control laboratory setting, aspiration was induced in laboratory animals, some of which had been given steroids, some of which had not. And those who had received the steroids prior to the event did better. But you know, once the event happens, it's too late for the steroids to help. Now, the next example of a pulmonary complication is less immediately obvious, and we should be able to put it together. A man with advanced pulmonary tuberculosis is undergoing a laparotomy for resection of a perforated terminal ileum secondary to intestinal TB. Halfway through the case, it becomes progressively difficult to bag him, and his blood pressure steadily declines while the CVP steadily rises, and there is no evidence of intra-abdominal bleeding. The setting here, if we look at each of the steps to analyze how we arrive at a diagnosis, the setting here is surgery on a patient with damaged lungs. In his case, damage from long-standing pulmonary tuberculosis. As in many of these general anesthetics, the patient is intubated and there is positive pressure breathing, in this case being applied by the hand of the anesthesiologist, inflating the lung, through a rubber bag. Well, in that setting, it is possible for a little pulmonary bleb to break, so that now that positive pressure is injecting the air not only into the lungs but into the pleural space. And it is entirely possible that a one-way valve situation has occurred to where we inject the air with every breath but do not remove it with every expiratory movement. And so eventually a tension pneumothorax develops. And in fact, if we look at the rest of the vignette, it is evident once we are thinking along these lines that there is a tension pneumothorax developing. The blood pressure is going down as the CVP is going up. And then there is that added tidbit of information that is becoming more and more difficult to push that air into the lungs, because we're now pushing it into this highly, high pressure tension pneumothorax. The management here obviously is to immediately empty the pleural space. When we review this in the trauma setting, we talked about the needle that is inserted in the second intercostal space. That would not be easy to do here on a patient who's draped and undergoing a laparotomy, but the surgeon could very easily, through the diaphragm, do the same thing. So the immediate solution to this problem is a life-saving little hole made in the diaphragm with a needle, and then at the end of the procedure, a formal chest tube can be placed. We move now to a few examples where the post-operative complication is either disorientation or outright coma. We begin with a very brief vignette, number 26. 18 hours after major surgery, a patient becomes disoriented. If we have this on an exam question, and no further indication of what could be wrong with the patient. The first thing we want to check is blood gases. This is a post-operative patient, and the likelihood that he's developed pulmonary insufficiency is pretty high. And that would be a reason for the patient's brain not to function adequately. It's a little different from the setting where a patient arrives in an emergency room in coma. There we think of a drug overdose, we think of a diabetic who's injected himself with insulin and skipped a meal. So we think of blood sugar, and we think of a toxicology profile, and we inject the patient right away with 50% dextrose and that sort of thing. But in the case of the post-operative patient becoming disoriented, if we have no further clue, let's first of all check blood gases. Chances are he is hypoxic. In the next vignette, we have a more complete description, in fact, of a situation where the problem is indeed respiratory failure. Vignette number 27. In the second week of a stormy, complicated post-operative period, in a young patient with multiple gunshot wounds to the abdomen, he becomes progressively disoriented and unresponsive. He has bilateral pulmonary infiltrates and a PO2 of 65 while breathing 40% oxygen. He has no evidence of congestive heart failure. This is a complete classical description of ARDS. The adult or acquired respiratory distress syndrome. The setting is your first clue. A previously healthy patient would not develop ARDS in a few hours. ARDS happens to the complicated, long, post-operative individual who's had all kinds of complications. And that's the setting here. A stormy, complicated post-operative period, multiple gunshot wounds to begin with, and then the disorientation and the unresponsiveness. And the classical findings are the pulmonary infiltrates, the low PO2, with no evidence of congestive failure. The management of ARDS is centered upon mechanical respiratory support and PEEP, positive end expiratory pressure. We already are giving this individual the maximum amount of oxygen that one can provide on a long-term basis. He's already at 40% oxygen. And in spite of that improvement in the oxygen mixture of what he breathes, he still has a very low PO2. The only thing now we can do is mechanical. Try to open up and use alveoli, try to push that oxygen across the membrane. And this is where the alphabet soup comes in, the CPAP, the PEEP, etc. PEEP, however, should be pointed out, can also damage the lung the same way that high oxygen content would. This patient cannot be put on 100% oxygen for several days because that would produce trauma to the lung and damage to the lung. As we put him on PEEP, though, we also could produce trauma and damage with the PEEP. So the PEEP is done in a very careful manner, allowing some degree of hypercapnia as a way to be sure that we're not pushing the procedure any more than it is necessary to do. There are a couple of additional things, though. If a patient has developed the acquired respiratory distress syndrome, there's a good chance that sepsis is present. So we should also be looking for a source of sepsis and taking care of it. So CT scans of the operative areas where an abscess could be hiding would be in order, and then drainage of those if they are found. Now the next one is easy to diagnose, but I'll tell you ahead of time, very controversial for the treatment. Opinion number 28. An alcoholic man checks in to have an elective colon resection. for recurrent diverticular bleeding. He swears to everyone that he has not touched a drop of alcohol for the past 6 months. In the third post-operative day, he becomes disoriented, combative, claims to see elephants crawling up the walls, and the wife then reveals that the patient actually drank heavily up until the day of hospital admission. Clearly, this is delirium tremens. These are DTs. This is the alcohol withdrawal that has been imposed by the post-operative situation where he doesn't have the opportunity to continue to drink. Now, as it happens, the DTs in the post-operative setting, as these are, have a very high mortality. So surgeons do not like that patients develop DTs while in the immediate post-operative period. And we have a way where we can reliably either prevent it from happening or treat it once it has happened. It's a very controversial thing, though, and it is the use of intravenous alcohol. In fact, what I would do for this patient, and many other surgeons would concur with that view, is give him 5% alcohol and 5% dextrose. I have to tell you, though, that psychiatrists would not agree at all with that modality of therapy for a patient who is withdrawing from substance abuse. And they point out to the incongruity of treating an addiction with the same agent that produced addiction in the first place. And yet the setting is different. This is not a patient who came to the surgeon saying, please help me stop drinking. And where the surgeon said, oh, sure, I can do that. I'll put the alcohol in your veins so you don't have to take it by mouth. The setting is one where the immediate objective is the survival of the patient in a post-operative period. The surgeons feel that in those circumstances it is acceptable to defer the treatment of the addiction, to a more favorable time. Now let me reassure you again that you would not be giving on the USMLE a question that has two potentially correct answers. So if you are given this question, if it was written by a surgeon, and that surgeon is in the habit of using intravenous alcohol to get out of this problem, intravenous alcohol then will be the only acceptable answer offered. It will not be there along with the other pharmacological therapy that is commonly used for the DTs. All right, let's move on to another situation. Opinion number 29. 12 hours after completion of an abdominal hysterectomy, a 42-year-old woman becomes confused, lethargic, complains of severe headache, has a grand mal seizure, and finally goes into coma. Review of the chart reveals that an order for 5% dextrose in water, D5W, to run in at 125 cc's an hour was mistakenly implemented as 525 cc's an hour. Well, we have now, with that bit of information, a pretty clear description of the setting in which acute water intoxication develops. A patient who is in the immediate post-operative period has inappropriate secretion of ADH because of the metabolic response to trauma. It's part of the normal way we respond to a major challenge such as an operation. If in that setting a patient receives a large amount of fluids that contain no sodium, like D5W, that water is going to be retained, and that will lead to the acute water intoxication. If you were asked what you think the diagnosis is, it is acute water intoxication. If you were asked what test would you do to confirm that suspicion, it would be a serum sodium concentration. Because the serum sodium concentration that probably was 140 at the time the operation was done is now much lower than 140. It's probably now in the vicinity of 120. It went down rapidly as the water was retained. You're asked about the management. The management is very controversial because this situation described in this vignette has a very high morbidity and mortality, almost regardless of the therapy used. Most individuals would probably use very careful administration of hypertonic saline because this is not a chronic hyponatremia. This is a very acute hyponatremia. Now, you're aware of the fact that in chronic hyponatremia, if we reverse it quickly with the use of hypertonic saline, we are very likely to produce that central pontine myelolysis syndrome that can be devastating to the patient. But in this situation where it happened acutely, and in fact the presence of the CNS symptoms pretty much indicate the brain hasn't had a chance to adapt to the problem. The EDOs, most have not yet been produced, that sort of situation. In that situation, it would be probably acceptable to use the hypertonic saline. You could use mannitol along with that. But again, it's a high mortality, morbidity situation. Well, we could have the reverse situation appear in a vignette. Vignette number 30. 8 hours after completion of a transsphenoidal hypophysectomy for a prolactinoma, a young woman becomes lethargic, confused, and eventually comatose. Review of the record shows that her urinary output since surgery has averaged 600 cc's an hour, while her IV fluids are going in at 100 cc's an hour. Well, here the mechanism is the opposite of the previous one. In the previous one, there was inappropriate ADH coupled with a large infusion of fluid. Here we have inability to produce ADH, probably because of a surgery in the vicinity of the posterior pituitary gland. There has been a transient interference with either posterior pituitary itself or maybe the stalk. And so the patient is not producing ADH. There is now a brief surgically induced diabetes insipidus. We can tell that that's happening because there's a very large urinary output, which certainly doesn't match the intake that she's having, and the intake in turn doesn't match the output that she's having. If we were to be asked what's the test that would confirm the diagnosis, it would again be serum sodium concentration. Now it would be higher than normal. If we assume she went to surgery with a serum sodium 140, now it's likely to be 155 or something like that because of all the water she has lost in the urine. Well, this lady needs replacement of the water that she lost. Because this is an acute situation, we could reverse the tonicity relatively rapidly without fear of inducing a problem. So this lady could receive several liters of D5W, 5% dextrose water. Because there is always that concern about what happens when you change tonicity too quickly, some physicians would prefer to use third normal saline or fourth normal saline, and that would be a good answer too. So pick the answer in there where you replenish the fluid that has been lost with either a pretty diluted fluid like 1/3 normal saline or 1/4 normal saline, or outright the most diluted of them all, which should be D5W. You could also provide this patient with ADH, which can be absorbed via the nasal mucosa. And the next vignette, vignette number 31, we have another situation which pretty clearly indicates the nature of the problem. A cirrhotic patient goes into coma after an emergency portocable shunt for bleeding esophageal varices. In this setting, we know that ammonia is the thing that's causing it. So ammonium is what we're going to be measuring in this patient. It'll be elevated. If the patient also has hypokalemic alkalosis and high cardiac output and low peripheral resistance, we actually have overt liver failure. And either of the two could happen. When we operate on a cirrhotic for bleeding esophageal varices, we're operating a patient that has a belly full of blood. And that blood in the GI tract, we're absorbing the ammonia from there that the bad liver cannot convert to ammonium, and you may end up with the, the ammonium that cannot be converted to ammonium, and we can end up with ammonium intoxication. But we also know that diverting the portal flow, as we do in the portal table operations, also damages that limited liver function even more than it was already limited. And so we could have either the problem due to the ammonium intoxication or due to overt liver failure. If the problem is ammonium intoxication, we would clean out the bowel, enemas, locally acting antibiotics to get rid of the source of ammonia. Now we move to urinary complications. Let's begin with something that's extremely common. Vignette number 32. 6 hours after undergoing a hemorrhoidectomy under spinal anesthesia, a 62-year-old man complains of suprapubic discomfort and fullness. He needs to void, he feels the need to void, but has not been able to do it since the operation. There is a palpable suprapubic mass that is dull to percussion. Classic. This is urinary retention as a postoperative complication, an extremely common thing. Any operation we do, the abdomen, in the lower abdomen, in the inguinal areas, and the perirectal area, any of those operations are very likely to upset that very delicate balance between the detrusor of the bladder and the bladder neck, and end up with urinary retention. And that's why one of the classical standard post-operative orders on any surgical patient is for the nursing staff to alert the treating physicians if the patient hasn't voided, typically in 6 hours, maybe 8 hours after surgery. Well, the thing we need to do then is to empty the bladder. So the answer for management for this one is to put a catheter in the bladder and empty the bladder. In most people, would do in and out catheterization the first time around. If it needs to be done again 6 hours later, at some point, the thought then comes into our minds of leaving an indwelling catheter. Some physicians do it with the second catheterization. Some physicians wait until the third one. But again, the solution to this problem is catheterization of the bladder. This problem is actually so common that if the kind of operation we've done predictably is going to produce urinary retention, we don't even wait for it to happen. We leave an indwelling catheter as part of the operative act. And this can lead then to other interesting clinical presentations. Vignette number 33. A man has had an abdominoperineal resection for cancer of the rectum, and an indwelling Foley catheter was left in place after surgery. The nurses are concerned because even though his vital signs have been stable, his urinary output in the last 2 hours has been 0. But let me start by pointing out to you that a urinary output of 0 is not what happens when a patient is behind on fluids. It's not what happens when a patient goes into renal failure. It's not nature's way to go to an output of 0. Now, we could see it if there is absolutely no perfusing pressure. But we've been told in the vignette the patient has good vital signs, they're stable. So the kidney is perfusing. If he was behind on fluids, if he had renal failure, he still would be making urine. Admittedly a small amount, but still making urine. So when we see urinary output of 0, we immediately think of a mechanical problem. If this individual has an indwelling catheter, the catheter is plugged or it's kinked, it needs to be straightened out, it may need to be changed, it may need to be irrigated, but that's where the answer lies. So don't pick the answer for the diagnosis. That is renal failure, that is acute tubular necrosis, that is insufficient fluid administration, because none of those would have produced a urinary output of 0. Look for the mechanical answer. But on the other hand, if we have oliguria rather than anuria, then we're talking about the classical differential diagnosis. Let's read vignette number 34. Several hours after completion of multiple surgery for blunt trauma in an average-sized adult, the urinary output is reported in 3 consecutive hours as 12 cc's an hour, 17 cc's an hour, and 9 cc's an hour. His blood pressure has hovered around 95 to 130 systolic during that time, so there is perfusing pressure. This low urinary output is not a reflection of shock. The patient is not in shock. So with a patient not in shock, but oliguria, now the 2 classical things to think about are either we are behind on fluids, patient needs more fluid administration, or acute renal failure has developed, both of which are common clinical situations. How do we know which of the 2? There are actually a number of ways we can do it. There is a pretty reliable, low-tech, cheap way to do this, and it's a bolus administration of intravenous fluid. This is the way this is commonly done in the third world. You take 500 cc's of normal saline and you infuse them in 10 or 15 or 20 minutes, and that rapid infusion of a bolus of fluid in the patient who is behind on fluids will result in an increased urinary output, even though if it's a transitory one. The patient in renal failure, on the other hand, is already making all the urine he can make. An increase in fluid intake will not change that oliguric state. Well, this is sort of a low-tech way to do it. There is a more elegant way, which is probably the answer will be offered on the exam, and this is to measure urinary sodium concentration. Because if you have a good kidney that is desperately holding on to fluid because the patient is behind on fluids, that kidney is holding on to fluids by way of sodium retention and the water that follows, and therefore the urinary sodium concentration will be very low. It will be below 20 milliequivalents per liter. But on the other hand, if what we have is acute tubular necrosis, acute renal failure, that kidney is virtually making a filtrated plasma. It doesn't have the ability to change the concentration of sodium. The sodium concentration in that urine will be high, will be higher than 40 milliequivalents per liter. This can also be done in a slightly more elegant way by calculating the fractional excretion of sodium, which in renal failure exceeds 1, and if you're behind on fluid, is below 1. And so then the appropriate management would ensue, either more fluid, if we're behind on fluids, or on the contrary, fluid restriction as a first step in taking care of the renal failure, if that's what the findings suggest. When I move to a few vignettes that have to do with abdominal distension, 2 very common situations. Vignette number 35. 4 days after exploratory laparotomy for blunt abdominal trauma, with resection and reanastomosis or damaged small bowel. A patient has abdominal distension without abdominal pain. He has no bowel sounds, has not passed flatus, and his abdominal x-rays show dilated loops of the small bowel without air fluid levels. Early in the postoperative course of a long, difficult, complicated intra-abdominal procedure, we expect that the patient will have paralytic ileus. And this, within 4 days, as this vignette describes, still well within the time frame for that to be the case. So if you were asked, best diagnostic guess what's happening here, you would say paralytic ileus. It still makes sense that 4 days after this long, complicated laparotomy, there are no bowel sounds, the patient is not passing out, and after all, he's not otherwise ill. He doesn't have abdominal pain, there are no signs of peritonitis, so this is probably paralytic ileus. You might be asked, incidentally, What laboratory test would you want to do under these circumstances? And if you were asked that, it would be a serum potassium determination. Hypokalemia can compound and perpetuate the paralytic ileus that we often see in all postoperative patients. But if a few more days go on with the same inability to move things in the bowel, then we have to begin thinking about mechanical intestinal obstruction. Most commonly it would be from adhesions, and adhesions can form early on and produce obstruction early on. It could potentially be the suture line that, we sewed up the back wall together with the anterior wall, that sort of thing. And so what would lead you to think of those would be if a vignette says it's now 6 or 7 or 8 days post-op, and there's still no bowel sounds, no gas coming per rectum, the patient is distended, then the mechanical problem comes to the fore. The diagnosis for the latter can be made with what's called a barium tag. Not a formal barium study with a gallon of barium that the patient drinks, but a very small amount, about 30 cc's of barium. They are injected through the nasogastric tube, placed in the stomach. And even if there is paralytic ileus, that is to say, if there isn't normal bowel activity, in the absence of a mechanical obstruction, that barium will slowly make its way down the GI tract and end up in the colon. So the barium tag is given, and serial x-rays are taken every 3 or 4 hours. And we follow the progress. As long as that barium tag is moving, it appears in a different place in each of the subsequent x-rays, we are confident that we don't have a mechanical obstruction. But if that barium tag hangs somewhere, it gets to a point, and the next x-ray is still in the same place, and the next x-ray is still in the same place, we have a mechanical problem. The patient then needs a reoperation to take care of either the adhesions or conceivably the anastomotic, defect or whatever. Now, vignette 36 gives us a different kind of abdominal distension, again very easy to recognize. An elderly gentleman with Alzheimer's disease who lived in a nursing home is operated on for a fractured femoral neck. On the 5th post-operative day, it is noted that his abdomen is grossly distended, tense, but not tender. He has occasional bowel sounds. X-rays show very distended colon and a few distended loops of small bowel. This one is Ogilvy's syndrome. Very commonly seen, poorly understood, I might add, and yet very commonly seen. Here are the things that allow you to identify this one right away. This Ogilvy syndrome, this massive colonic dilatation, we already read the X-ray report, massive colonic dilatation, is typically seen in elderly patients who were not very active to begin with, like this one, Alzheimer, living in a nursing home, who then are further immobilized by an operation which frequently, in fact typically, is not even an abdominal procedure. In this case, it was a hip, pinning or operation on the hip. And they then develop this somewhat mysterious, poorly understood, but commonly seen massive distension of the colon. It's almost as if it were a paralytic ileus of the colon, instead of the standard paralytic ileus of the small bowel, which is the one the previous vignette referred to. So we have already made our diagnosis because of the setting, because of the circumstances, and the X-ray findings. The management then, the next thing we're going to do is a colonoscopy. By doing a colonoscopy, we achieve 2 or 3 things. First of all, as the instrument advances and gets all the way to the cecum and eventually is retrieved, we can suck out all that gas that is now dilating the colon. If you remember, when a colonoscopy is done in another patient, in a normal patient, the way we open up the bowel wall so the instrument can go in is by insufflating air. But in this case, the insufflation already took place by virtue of the disease, so we can easily put the instrument in, but the same channel that is used to insufflate and to, retrieve the air for the colonoscopy is now used to suck out the gas that is already there. We've achieved a second objective, though, because all people that develop Ogilvy's are also good candidates for cancer of the colon. That's where we see cancer of the colon, older patients. And certainly a cancer of the colon could occlude the lumen and lead to massive colonic distension. So the colonoscopy rules that out. And then at the end of that, a long rectal tube is left in place so that there is an avenue for continued exit of the gas, even in the absence of good propulsive motion. Very rarely, if there is a massively distended cecum, we might be compelled to do a cecostomy or a colostomy or a derivation of some type. Most patients can be handled with a colonoscopy.